Proceed, Jonathan.
Prophet's Lorato, she's starting off the presentation.
No problem, Lorato, go ahead.
Okay. Hi, everyone. We are presenting.
Lorato, if you could just make sure your volume's a bit better. You're not very audible.
Oh, okay.
Just come closer.
Can everyone hear me clearly?
Better.
Okay, thank you. We are presenting HIV counseling, myself, Jonathan Hudson, and Shirastan Naidu. My name is Lorato Tomahole.
Lorato, we are struggling. It's disappearing again.
Is it disappearing? Is it better?
Yeah, much better now.
Okay, thank you. So the objectives of this presentation is to help encourage active HIV testing from patients, as well as ensure thorough counseling from our counselors, and establishing a synergy between educating the patient as well as information overload, which we know happens a lot, as well as improving health-seeking behavior and altering the attitude and behavior of the healthcare worker and the patient, and striving for adherence. So we want to ensure that the patient is able to process and manage their test results, assisting those who are negative to remain negative, as well as assisting those that test positive to minimize the medical, social, and emotional impacts of HIV on their own lives and those that are close to them. So the 5 C's of HIV testing, according to WHO, is consent. So we want to obtain verbal consent, which is adequate, but also offer the patient an opportunity to refuse testing, as well as giving an opportunity to test later if possible. Confidentiality, meaning that we ensure that the patient understands that all the results and their information will be confidential, and disclosure to any sexual partners or any supportive family members is only with the consent of the patient. With counseling, we want to offer simplified counseling to patients. Simplified meaning that they can fully understand what we're saying and not using complicated medical terms, as well as giving correct results. So we need to ensure that the patient receives correct test results according to the national guidelines, and offering a connection between the patient and any HIV prevention, treatment, and care, whichever would be applicable to them according to their test results. Okay. So all HIV counseling and testing services must include accurate and sufficient client patient-centered counseling that will address the client's risks according to their profile. All clients should be given their results immediately, unless if the testing method does not provide for results immediately. In such circumstances, we'll want to bring back the patient in about 5 days to receive their results and treatment accordingly. Disclosure of results, as said before, should be done in the best interest of the patient, or if ordered by court of law, even if in such circumstances, the client should be informed prior that their results will be disclosed. And HIV counseling is divided in between pre and post-test counseling. So this is just a diagram showing the different aspects of HIV counseling, whether it's a VCT or provider-initiated testing and counseling, and the different facilities at which they can take place. So for pre-test counseling, we want to provide the patient with as much information on the acquisition and transmission of HIV, and as well as emphasize the importance of early testing to facilitate diagnosis and positive living and lifestyle, as well as including what viral control is to the patient and explaining that thoroughly. Information about the HIV testing process and the meaning of what a positive result as well as a negative result, and the diagnosis and what's to follow from there, as well as to discuss potential inconclusive results and the steps that follow, because often patients would get a positive and negative and not enough counseling as to what that actually means, and the fact that they have to come back for their final results that need to go to the lab. and a discussion on confidentiality and shared confidentiality. Offer an opportunity to test at a later stage should the patient decide to decline the testing, and assuring them that declining the test does not restrict their access to further medical services. And the importance of TB symptomatic screening during the pre and post-test counseling. So we want to offer the patient during the pre-test counseling, ensure that the patient knows with the results there is actually services that are available to them post-counseling, such as nutrition, TB screening, STI screening, and annual pap smears, as well as CD4 count and viral monitoring and any opportunistic disease prevention. We come across so many female patients that don't know or neglect the fact that they need to do annual pap smears if they have in fact tested positive for HIV. Importance of partner testing, especially in ANC settings, and emphasizing the fact that an individual status is not a couple status. As in the workplace, you find a lot of males especially would say their partners have tested during pregnancy and therefore their status is shared, as well as information about effective HIV prevention measures, including consistent and correct use of condoms, partner reduction, and other options. To assess who will provide client with support and to provide opportunity for patient to ask questions post the pre as well as the post-test counseling. So it's important to know that according to the National Health Act, all information concerning a client, including their information relating to his or her health status and treatment or stay in a health establishment, is confidential, and no person may disclose any of this information unless the client consents to this disclosure or a court orders this disclosure to happen. So, sorry. In pre-test counseling, you also want to assess the individual's risk and when their possible exposure may have occurred, and determine whether there has been a history of domestic violence, and or offer any social or psychological support accordingly. Discuss the partner's involvement and refer the partner for testing as previously stated. As well as assess who can provide the client with support. As we know, so psychological support as well as social support is very important for patients with any disease.
Okay, so I'm Suresh, and I'll be discussing the post-test counseling aspect. So post-test counseling should be offered irrespective of the outcome, and there's 3 outcomes that I will go into. That would be positive, negative, and indeterminate. So for an HIV negative result, this information should include the advantage of MMC, which is male medical circumcision. And I listed this because it was shown that MMC showed a 60% reduction in the transmission of HIV according to the World Health Organization. So it's been implemented in our guidelines. Also TB screening, risk reduction, so that would be abstinence, correct and consistent use of condoms, starting treatment if pregnant, not sharing needles, and the list goes on. And the correct and regular use of condoms. We should also suggest that sexual partners should also be tested and possibly encourage couple testing and information regarding when to retest. So with an HIV indeterminate, so what exactly is this? This would be a result that would be given if the screening test and the confirmatory tests are repeatedly discrepant. And these situations are rare. However, it may be a consequence of either systematic error by the healthcare practitioner or just an error with the sorbent assay. These individuals should be asked to return in 14 days, as Lerato said, for further testing to get a correct one. And this would probably be the ELISA, as discussed by the previous case that we did. Ultimately, sharing information about the HIV status with trusted members should be encouraged. Okay, so for an HIV positive, there is quite a bit to discuss here. They must be given the results in accordance with the national algorithm and offered comprehensive post-test counseling. And this would include the TB screening, importance of early care and treatments, whether they are eligible for CD4, if CD4 testing is conducted, disclosure and partner family testing, and how to reduce the risk of HIV transmission. A positive patient should be informed and counseled about possible emotional responses. That would be denial and anger. I mean, everyone deals with bad news differently, so they should be enlightened on what the potential outcomes could be and when they can seek help and what exactly help that they can seek with respect to this. And once they've dealt with their emotions appropriately, they can seek methods for adherence and choose healthy life choices. Comprehensive information to also be supplied pertaining the importance of positive living, healthy lifestyle and nutrition, and referral to psychosocial support, being big support groups, and drug and alcohol rehabilitation should also be provided when needed, of course, based on when the patient is ready. Furthermore, patients who screen positive for symptomatic TB signs should be referred for diagnosis if suspected of having TB. After the post-test counseling has been completed, the fifth C that Lerato mentioned, which is continuity, and treatment of services should be established, and they can assess their severity by staging with the CD4 or clinical staging by a clinician who's trained in HIV AIDS. So that'll be either WHO stage 1 to 4. Okay, so with the testing issues, there have been a number of issues, and they've been categorized nicely in this table, be it the health system issues, that being stock taking issues or lack of support or lack of working staff, testing guidelines and sensitivity of kits. There's actually been a discrepancy in when people should retest and what they should do. A lot of people like doing the PCRs incorrectly, or they just prefer doing the ELISAs rather versus the rapids. So there've been a lot of mistakes in that regard, and low incentives and the stigma fear or denial of testing. This table is quite comprehensive, so you can have a read of it later.
My name is Jonathan. I'll be doing HIV counselling and testing in special populations, starting with adolescents and youth. So according to the Children's Act, a child is defined as a person under the age of 18. However, the National Strategic Plan for HIV, STIs, and TB broadens the category to include youths aged 10 to 24 years old. This age group is particularly at risk and growing for two main reasons. The first being the aging up of perinatally infected children in the 90s and 2000s, as well as a population boom leading to the largest generation of young people in history. As a group, young people face increased risks of contracting and transmitting HIV due to early sexual debut, sex with multiple sexual partners, unprotected sex, substance and drug abuse, high risk of sexual coercion and abuse, high frequency of sex, age difference, and age differences in relationships, to name a few. So ideally, service providers in this context should include the following: a sound understanding of youth-friendly pre- and post-test counseling approaches with understanding of adolescent development, and provide appropriate medical, psychosocial, and developmental options according to the patient's age and maturity levels. Services should be youth-friendly, and they allow young people to be at ease during the interaction and comfortably able to communicate their needs, questions, and personal concerns. As far as possible, services should attempt to provide services to young people in a one-stop shop fashion. So it's been noted that whenever young people are sent to a further location for another service, there's an increased risk that they will not show up. These services should include adherence counseling and support, sexual and reproductive health services, as well as mental health support. Where comprehensive one-stop services provisions are not possible, it is important that staff refer and link young people to responsible agencies that provide appropriate youth-friendly support. HCT programs should involve adolescents in design, delivery, and evaluation of their services in order to assure that these programs address their unique needs. Okay, in terms of pre-test counseling, the counseling session will largely be driven and determined by the patient's age, development, maturity, and as well as level of understanding. In terms of the content, it's largely similar to adults in terms of the information given. For example, what is HIV? How could an HIV test help? What is involved with the test? What does a negative and positive result mean? And what to expect after receiving the result. Children should be encouraged to express themselves openly throughout, as well as ask questions and raise any concerns. In terms of post-test counseling, it's important to assess the readiness to receive the result. Also, information conveyed across to the patient should be informed according to age, development, maturity, and level of understanding once again. It's also important to assist in understanding and accepting of the result, as well as its subsequent implications. It's also important to assist the child or caregiver to make decisions regarding appropriate follow-up care and support. The next population we're going to look at are survivors of sexual assault. With this population group, it's important to note that counseling should always precede and follow testing. Pre-test counseling specifically needs to allow for additional time for exploration of the victim's feelings, as well as performing a risk assessment. It's also important to provide information about post-exposure prophylaxis, STI prophylaxis, as well as emergency contraception. If the patient tests negative, it's important that PEP is continued. If positive, PEP is to be discontinued and appropriate referral for further HIV care and treatment services, as well as medical legal support. If the client is not, however, emotionally ready to be counseled and tested, they should be started on PEP with a 3-day starter pack and encouraged to come back for an HIV test. Patients receiving PEP should be encouraged to test again for HIV in 3 to 6 months after the initial exposure. PEP administration in the context of a comprehensive support program that include syphilis testing and treatment, pregnancy testing, emergency contraception, screening for Hep B and C, as well as the tetanus vaccination where appropriate. It's also important for referral. It's also recommended that referral is to experienced counselors as well as crisis center counselors, that these services are encouraged when available. It's also important to note that multiple sessions in these contexts may be required. In terms of alleged sexual offenders, any survivor or person acting on behalf of a survivor may apply to a magistrate for an order that the alleged offender be tested for HIV and that the results be disclosed to the survivor or interested person and the alleged offender. The healthcare worker should offer all the necessary pre- and post-test counseling, as well as the alleged sexual offender should be provided with all the necessary information with regards to HIV and AIDS. In this case, ELISA testing is used to test an alleged sexual offender, and strict requirements apply to confidentiality of results. The results may only be handed to the investigating officer in this case. The survivor or the interested person who applies for the testing of an alleged sexual offender should be counseled prior to receiving the HIV result of the alleged sexual offender. The investigating officer must ensure that such counseling occurs before handing over the test results. The next population is specifically looking at prisoners. Although there's little data regarding HIV prevalence rates among prisoners, it is noted to be a high-risk group in South Africa. No prisoner should be forced or coerced into having an HIV test. During admission to and release from a detention facilities, authorities must screen detainees for STIs and TB and provide the necessary treatment. It's also important that they receive full HIV counselling as well as testing. It's important to advise prisoners of the risks of sexually transmitted infections and HIV in the prison context, as well as provide condoms to prisoners during pre- and post-test counselling. It's also important to counsel between the difference between consensual and non-consensual sex. The administration of PEP following sexual exposure or abuse according to the national protocol. Inmates should be informed about PEP at the time that they enter the detention facility. For females, it's important to provide basic antenatal care, including HIV testing and counseling, in accordance with the approved PMTCT. Next, at-risk population is men who have sex with men. Their HIV prevalence rates are much higher than men in the general population in South Africa. HCT counsellors should consider the following when designing MSM-friendly services. Additional training should be provided to healthcare workers in this context to sensitize them to the special needs of MSM and to ensure that they are comfortable discussing sex between men during risk reduction counselling. It's important to create safe spaces where men can talk openly and receive HCT services without fear of stigmatization. It's also important to integrate HCT services into other services designed for MSM. It's been found that preventative messaging directed at STIs in general has a slight better effect than addressing HIV directly in this population. And that is all. Thanks.
Thank you very much. Very useful that you guys focused on some of these vulnerable populations. I think it's important to keep that in mind. With regards to counseling, I want to remind people about PICT, which is provider initiated counseling and testing. All of us should feel obligated on any occasion that we see a patient who is warranting a test to actually say, I need to do a test. And a patient can object, of course, but you need to argue the case that I need to do this test, and it's an important part of the process. It also can be that you do it routinely, and generally, if a patient has got high risk behavior, looking at the ABCs, you'd need to advocate that, yes, an annual test at least would be something that the person needs to do. And then again, to offer it and argue for it. So please don't wait for patients to ask you for an HIV test. That's not good practice at all. So in terms of, one of the concerns that everyone has would be, I don't have the time, that's a long story. It doesn't need to be. And I think that's one of the problems with HIV counseling and testing. I think like I think one of the colleagues said, it's a long list. It doesn't need to be. Firstly, when you are doing pre-test counseling, post-test counseling issues need to be part of that pre-test counseling. So please, when you give a result to the patient, negative or positive, you want to just reinforce some issues, but that would not be the first time you talk about the issues. I mean, imagine yourself in that seat getting a result of a test and what goes on through your brain, and suddenly the result comes negative or positive. Will you actually listen to that caregiver sitting across the table, winding on? It's not going to happen. So it's best not to give new information post-test. Post-test, best thing to remember about it is shut up and listen. Let the patient express themselves, and then try and remember to reinforce some of the issues that they would have discussed prior hand. So you're really just pinning down that, okay, we discussed this and you said you do X, Y, Z. So pre-test counseling is actually most of what you do. And you've got lots of ideas there. And I would like to just pin some key things. So firstly, when you are in a situation where you're saying, I need to do this test, you should be able to say, do I find myself in a position where if I ask a question and the person responds, do they seem like they know most of what I think they need to know? If you find yourself explaining to people more, if you find yourself talking to people more than they're talking to you, there's a problem. And so what you should do is you should in fact refer that person to a counselor who might give them information, which is the usual practice of giving tons of information. You can refer them to written resources online, whatever, but get them to get that information. But as a clinician, you need to ask some key questions and focus them in a way that gives you the sense of where is this person. In there, you might say stages of change, because doing a test and embracing a lifestyle, different lifestyle, and adopting possible treatment is a change behavior, and we need to be sure. So it's a lot about exploring, not telling. So information giving isn't the best idea. It's about you as the clinician using your time very valuably asking very, very key questions. Some of these key questions that you need to clarify is, do they understand what the HIV, what HIV is? And particularly what you're concerned about is not, helper cell, T cells, anything that you think is, complicated stuff. What you want to understand is, do they understand that this doesn't cure and that it's a lifelong disease, which can be in you without making you sick, and that it will go on for a long time. So that is, in fact, I think a key concern. The second thing you need to be able to establish is, do they, firstly, you need to be able to be sure about their mental health. I think somewhere in that conversation, even before, be sure that you've got a sense of the person's mental health. Even if you're asking explicit questions around depression or suicidal ideation, you want to be sure there's not a person who's in fact depressed for other reasons. Well, then you ask about the HIV. You want to ask about what do they know about the HIV test. Sorry, before the test, you want to know what their risk behavior is. Do they understand how HIV transmits? And if they talk about blood, etc., you're missing the point. They need to be talking about, firstly, that's sex, and that their behaviors around sex matter. So you need to see that quite clearly, and that they have taken caution of their using the ABCs. The third one is that you need to be able to know that they know what is involved in a test. You then need to see what they know is involved in treatment, and that it is needed to be ongoing for life. You can also ask the question, what if you're positive? What if you're negative? And see what they know about those kind of responses. And when you get quick responses, you don't need to, and quick and very articulate responses, you can shut them down. So this can be like six or seven quick questions. You get a sense of the person. Oh, this person really has a good idea of what's going on. You can say, fine, let's do the test and repeat them. And in the consultation, you might have an outcome. And I think we should be moving towards that rather than saying we need to refer to specialist others. Primary care, HIV management is part of primary care. It's not a specialist part, not a part of specialties. It's part of routine care. Okay, well, let's stop at that. We've got another set of people that will present. Is it Chloe? Thank you very much, guys.
Yes,
let's just quickly, before you go, let me just quickly share. You can just give the presentation a rating, and then we can move over to Chloe. Just give them a rating quickly. And we need to talk about how, at some point in the next block, I guess, how to judge good presentations so that you're not just giving your pals nice marks. Okay, it's good feedback. We'll perhaps add some elements that could be improved. Well, thank you very much. Here's the results. So good to very good. Thanks, guys. Appreciate that. You can stop sharing and we'll continue with the next group. Thanks, guys. So adverse events, I think Chloe had asked on WhatsApp. So I'm just going to take it as people are asking me. And I think that's Chloe, and then we can Nicholas, and then the next. All right. Okay, so Chloe, you're able to share? Before you can just share, and if you are Chloe, you able to share?